out how you promote that and start tomorrow, and that's going to be your career, at least for the intermediate term. So you go to your first job, establish clinical credibility as a mainstay. Be comfortable in your own skin in what you're doing. Work towards autonomy, but keep those around you updated, keep your bosses updated, get help when you need it, and don't avoid getting help when you need it. Develop an academic focus and consider additional training to help you advance your career. Everybody doesn't need an MBA, but a few of you will benefit from an MBA, and that applies for other areas in your academic work. Okay, what are faculty tracks? I think everyone knows this. Most of you are going to be in a clinician track, focusing on clinical care, patient care. Every institution's a little bit different, but most are pretty similar. There'll be a clinician track. There'll be an investigator track that has a high proportion of funded, focused research, whether that's basic science, translational, or health services, and then pure research tracks. And probably very few of you are going to be in a pure research track. Okay, what are those job tracks going to lead towards? Assistant professor, you're going to be expected to have increasing levels of independence. To make that next jump as an associate professor, at least at most institutions, the expectation is that you will have developed national recognition by peers and have an independent body of work of focus. That takes probably minimum 5 years for any surgeon, and sometimes 7, 8, 9 to make it. And then at the professor level, also that'll be another 5, 7, 8 years for most. The person needs longevity. They need national and international recognition for contributions in a unique area. So this is the pathway to start on. I'm still somewhat amazed, a number of even kind of experienced surgeons that say, nobody's told me what I'm supposed to do to get promoted. I hear that all the time. It's pretty straightforward what you need to do to get promoted, and this is it. Develop an area of expertise and focus that you can articulate, but that others can articulate about you, what you've accomplished, what you've done, what's unique in your career, and that you're skilled in a unique area. All right. So there are a lot of recipes for success. You need mentors and your faculty that'll help you along the way. You need annual career development contacts with your bosses. You develop your CV, you meet, you talk about your career pathway, you review goals that you had for the last year, goals for the next year, and you need to be doing that on a regular basis. This is kind of how we do this. The faculty develop their career plan and maintain their practice areas or clinical focus areas. As an aside, always maintain your professionalism, always adhere to a code of conduct. I mean, this is a minor aside. You think, who needs to hear that? Well, 10% of our faculty get sideways and have professionalism issues. Don't let that be you. It's a distraction for your career and your progress. So as I mentioned, this is an active, ongoing process. Review last year's plan, build on the plan, think about the next steps in your career. You will want to develop a clinical area of focus. Ideally, this meshes well with your academic area of focus, but it doesn't always. But you need to have both, and you need to be able to deliver that elevator pitch, concise summary. If there is other areas of, if there are other areas of expertise and focus, make sure your boss or bosses know what those are. As you think about what you're going to need to do in that first job, politely let your bosses know about that. They can't help you if they don't know what you need. If there are things you're missing, figure out the way to politely get help from your boss. Try to have short-term and long-term goals. And this is true for all of us. What do you want to develop in the next 1 to 5 years? But what do you want to do for the next 25 years? Where do you want to be in 20 years or 25 years? And make sure your short-term goals mesh with those long-term goals. We plan that every faculty member will have that plan put together. We'll have the statement of their academic goals. And then work through the steps to achieve their goals with help along the way from their chiefs. So let me just tell you, diverge just for a second and talk a little bit about our current surgeons and surgical groups. So people talk about millennials. Let's talk about broader groups like me, for example. Identifiable groups can be put together based on, commonly this is done based on birth years. And there is some commonality that occurs that in this categorization. So you're not going to be working with traditionalists much anymore. They're out of surgery, but you are going to be working with baby boomers, and that they will be a lot of your bosses. So these are people born between 1946 and 1964, characterized, these are broad generalizations, but there's some truth, workaholics who live to work. I've been accused of this, who have, but I don't think this fits, who have self-sacrifice, are optimists, they look for personal gratification, they pay attention to compensation, but they're workaholics. Generation X, these are a little more skeptical individuals who lived through Watergate. Most of you in this room are fit in the baby boomer category. You know technology. You're empowered, maybe sometimes entitled. You are more relaxed. You like your job, but you're not just going to live for your job. And I think thinking about groups of individuals in this way is a little bit helpful. Think about how your bosses perceive things. It's helpful to think for your bosses to think about how you perceive things. In the last couple of slides, I'll just summarize. Think about what you want to achieve. Look for jobs that will help you find your way to achieve that. Define your future career goals. Think about those long-term goals. Try to pick a job and colleagues that will help you achieve them. And then I'm going to skip this CV part. But I would say these are the main components that people focus on. This was David Richardson put this forward as saying, what are the elements of professional satisfaction? Prestige in a job, economic rewards, and lifestyle. And it's a balance of the three. that most look towards for professional satisfaction. So in summary, work on finding a meaningful job, initiate that pathway for career success, plan for your promotion. It's never too early. Build your clinical practice, establish your national and regional expertise, and take a break periodically. Enjoy your work, enjoy your family, and enjoy your colleagues. You will not find the perfect job. Take your own pulse of advancement, consider course corrections, and appreciate your successes, but remain humble. Finally, I would point out a key part of your career is taking advantage of opportunity. Opportunity is defined as a favorable juncture of circumstances that sometimes involves risk, and often occurs after a destabilizing event. That certainly happened in my career. Think about when those opportunities arise. You have to think carefully about taking advantage of them, but take advantage of them when you can. I'll stop there. Thank you very much.
Thank you very much, Dr. Chapman. We appreciated that keynote. The next sort of series of talks is based chronologically. The first of those is by Haya Schwartz from the University of Toronto General Hospital in Toronto, Canada. She completed her general surgery training at both Sheba Medical Center in Israel, as well as Mount Sinai Hospital in New York. She then completed an HPB fellowship at Sheba Medical Center, followed by a fellowship in abdominal transplant and HPB surgery at Toronto General Hospital. She's the co-program director for the Abdominal Transplant and HPB Surgery Fellowship at the University of Toronto. She has clinical experience in MIS, HPB surgery, as well as a significant education. I've had the personal privilege of working with her when she was a fellow, so I can't think of anyone better suited to give our next talk, which is the final 3 months, how to maximize the end of your fellowship. Hi, Schwartz.
Thank you so much, both of you, for the invitation. I remember when I was a fellow and we talked about it a couple of years ago, I was actually sitting in your place and I was thinking to myself, I wish one day somebody will invite me to give a talk in this session, so thank you. And I will talk about the last 3 months of fellowship and how to prepare for the beginning of your career as an attending, how to maximize the last few months. So as mentioned before, Dr. Langer was the chair of the division in Toronto, was a very meaningful person for the program. Even though I was not trained by him, we kept hearing about him. I have a few co-fellows of mine and a few trainees of Dr. Langer here in the audience that I can see, and everyone can talk about how amazing educator he was, how he made everyone come to the rounds with the fellows and teach and learn together. So I just wanted to mention that. So it's not the beginning of the end. This is the end of the beginning. So now you're coming to the end of your training. The last 3 months, what can you do in the last 3 months to actually make the best of it and be prepared? So take some time to slow down and think things. You have to make sure not to operate too much in these last 3 months. I think that I can't stress this point more, but I think the last 3 months, instead of operating every day as you do in your fellowship, take a step back and think, what can you do with the time that you have? I think very important is to finish your obligations from before, right? Like you promised to do a research project, you promised to finish a book chapter. Think about what you promised to do and how you can finish it in these 3 months. It's really, really painful to start your position as a staff when you have so many things to plan in the beginning of your career, and then you get a phone call from your staff in your fellowship saying you didn't finish the project that you promised you're going to start. So take the time, these 3 months, to finish these things. We mentioned that yesterday we had a program directors meeting and we spoke about the HPBA requirements. And one of the things that we see is that we get a letter that the fellows didn't finish the requirements, which is obviously most of the times not true. They finish the requirements, but they're so busy as fellows that you guys don't have time to log in your cases. So take these 3 months, make sure you have everything ready. So you won't get a letter 2 months after you already finish and you started your job that it's a problem to give you the certificate because you forgot to put your cases in. So that's an important thing to do. Now, as I mentioned before, in my opinion, less is more. So I put here, and I have to give a shout to Brandon Wieser that sits there, because when I was a fellow, when I came to the fellows lunch, he told me, try to take as much notes as you can. So in the last 3 months, basically, when you step out a little bit and stop scrubbing every day and stand in the operating room and look rather than do the case, you can have a lot of notes for yourself, things that was your everyday, things that you did every day in surgeries. And then a few months after, when you suddenly need to do a case that you didn't do for a long time, that keeps you very focused and help you after that to plan your case. Also, I know how it is when you're a fellow and then the staff comes and changed. You started the case and put the retractor the way you like it, or you think they like it, and then they come in and change the retractor. I can see my fellow laughing because that's, but so I think take pictures, make yourself notes about how to plan your OR, what do you want to do with your time. Also, the other thing that is really, really important is when you watch, try to watch your staff, right? Like, what do they do? How do they have the exposure the best way? How do they explain to the fellow what to do? So that's very, very helpful for you, because soon enough, you're going to be standing on the left side and going to be helping your fellow and teaching your fellow. Because many times as fellows, you just do what you're told, or you go with the case, and then you kind of miss the point of what you do as later on when you take someone through the case. Reflect. So I know everyone as fellows always say, we all as fellows say that we saw the patients before, we look at the scan before, and we saw the patients after the OR, but it's very different if you do a little bit less and you have a little bit more time to reflect, you dip into the cases much more. So look at the scans, not just, 20 minutes before the case when you are running around and you just finished a transplant last night at 3 a.m. Take the time, do less cases, get more involved with the patients, look at the complications, reflect on how can you deal with the complication and how your staff and the other team members are dealing with the complications. I think complications in the beginning of the career is really hard. I mean, at least I know about myself that I really take everything to the heart and still, and I hope I will continue to care, but it's something that is hard to deal with, and I think it's something that you can learn a lot by looking at other people doing cases and kind of coping with their complications. So fellow cases. I think in this picture is our 2 fellows doing a case together. It's not always possible, but what you can do is ask to start the case. And then if you're starting the case and doing it 2 fellows, it's always good to teach each other, elevate each other, and you have each other, you also give each other confidence that you're both there and you can help each other get out of some situations. Always call for help, always have your staff around to make sure you're doing the right thing. If it's possible and you can do it, I think it's a very, very good to learn how to be taking someone to the case, and you always have someone around to help you, even if the staff is sitting in the room and looking at you and giving you a couple of hours to work together. Also, it's part of the requirements of teaching cases, so I think it's something that you can talk to your mentors about. So I think the other thing that very important and helpful in the last 3 months of your fellowship is to gather information. Think about what you want to do when you go after your fellowship and you go start your position. Gather information about protocols that you saw in your program as a fellow that you want to take with you. Look at the instrument list. For example, when you're a fellow and you say, okay, the instruments are there, but you go to your new institution, you ask for their tray and the stuff that you used as a fellow that you thought they were really amazing, but you don't have it in the new institution. So prepared for that. Another thing that was very nice to take also and to use is to take the patient education packages that you give, templates of the OR, templates of the clinic. That's really, really helpful. And it's something that, somebody else did it and now your fellows there, you're learning. Take these things with you and then adjust it to what you like and how you see yourself doing the same, procedures and the discussions with the patients. So this is really, really important point. It was mentioned before by Dr. Chapman, but I'm gonna say, like, you need to see what you expected to do. You know, you've been hired in a new job. What are you expected to do? And focus the last 3 months of your time doing the cases that you expected to be doing, right? So you'll feel confident when you start, you'll be according to the expectations. But also on the other side, you want to develop a niche and have a vision of your own. So if there is something that you're more interested in and you want to bring to the new program that you're going to, try to see if you can go into and doing these cases specifically rather than just scrap to more and more cases. You can focus much more. Then what about what's your, your vision as not only as a clinician, as a researcher or an educator? How do you plan your time? If you're going to build a lab, you can always sit with one of your staff that you have now that in your fellowship that has a lab and see what's the plan that you should have in order to start the lab when you're going to start it. What can you take with you in order to start a curriculum in another program? So all these things are very helpful. These conversations with people around you that already experience more than you and are your mentors and want to help you. Get organized. One of the best advices I got is like to sit and clear my desktop that was full of pictures all over of surgeries and stuff, and also clear my email. And another thing is prepare your CV, because you know how you start your career, you want to get to the point of advancing your career and getting promoted. So if your CV is a mess, it takes time, it makes everything unorganized. When you get to the time that you can actually get promoted, it takes so much long time to fix it. So I think that's really, really helpful as well. So talk to people. For example, we created a group of when we were co-fellows, a few co-fellows that we stayed in touch all this time, and we meet once in a few weeks and we go over cases, we talk about challenges, how to work with other partners, any issues that we have, and it's very helpful. Also build your foundation for mentorship. There's a few people that sit here that I still call and ask questions and talk about difficult cases or just interaction. And I think that's something that you can do very, very much at the end of your fellowship. You have many people there that care about you, that want to train you, so they will create this relationship with you and keep it after the fellowship. Then, of course, think about your family. So that's a drawing that my daughter put there, and obviously I'm on scrubbed as usual, but that also think about them. Go see schools for them. Think about in that 3 months, see things that you're in the new city that you're going to live, how you can make this environment better for your family. They've been there for us for a very, many, many years of training. So now it's the real deal. Now it's life. So think about them and what you can do to help them enjoy the life after the training. And then when I asked all my colleagues, what would you say to someone that for the last 3 months of the fellowship, how to make it the best? Everyone told me, tell them to just chill. So you're welcome to come to Toronto. As you see, it's an amazing city, but really take the time, because after all this training, not always you have time off before you start your new job. You want to really always the feeling that you want to start a new job and, right away get to the most complex cases, start the new program that you wanted to do, be the best as you can, the first impression and everything. So at least at the end of the fellowship, and by the way, the last month of the fellowship in Toronto, we make our fellows actually to step back. So in July, the second year fellows are stepping back and the first year fellows are stepping in, including all the cases, complex cases, vascular reconstructions, living donors. And then the second year fellows just give the first year fellow backup if they need anything or they need guidance. So I think and then they can take some time, be with the families, see the city for a change after 2 years that they didn't leave the hospital. And then this is for our second year fellows that are finishing very soon. We're very proud of them and dedicating this for them, of course. Thank you.
Hello, there you go. I have the honor of introducing Dr. Rebecca Minter today. At lunch, I told Dr. Warner I've been given the impossible task of introducing Dr. Minter, and she said it wasn't impossible, but she doesn't really need an introduction. And I agree. So I won't belabor her professional accomplishments in a room full of HPV surgeons. But I did listen to her keynote talk at the Association of Women Surgeons meeting this fall, and I can say she's remarkably humble, obviously very hardworking. And it's these characteristics that have brought her to University of Wisconsin, where she is currently the A.R. Curie Distinguished Chair of the Department of Surgery. She's also had leadership positions at University of Michigan and UT Southwestern, all very desirable places for employment. So this makes her kind of the perfect speaker to discuss with us today perspectives from the hiring committee. Dr. Minter.
Thank you so much, Shannon, for that kind introduction. I sadly continue to have no financial disclosures. I also will disclose I do not have COVID, and my 15-year-old son gave me some cold like 4 weeks ago. I have now this lingering reactive airway thing. So I promise I'm not infectious nor have COVID. I have hired a lot of faculty, though, in the last 5 years at Wisconsin, roughly 60 over 5 years. And so I've learned a lot. And actually, for once, you actually don't have imposter syndrome giving a talk because I have actually thought about this a lot over the last 5 years. And I think from my perspective, and I think anyone who leads a unit or a team feels this way, Jim Collins said it best, that, getting the right people on the bus, the wrong people off the bus, and then getting people into the right positions is really the most important thing that we do. When you hire the wrong person, it occupies, 90% of your time. And hiring the right people is how I'm successful because, as a chair, I bask in the reflected light of the successes of everyone in my department. So we spend a lot of time on this. We spend a lot of resources and focus and energy around this because, again, this is foundational to every single thing that we do in the department and every success and, quite frankly, every failure when we do it wrong. So from your perspective, and I'm sure many of you are in this hunt right now because it feels very much that way. Some of you may have already secured your opportunity, but sort of knowing what this cycle looks like, a lot of you probably are still evaluating opportunities. And I think I'm going to just provide you with some really tactical approaches to this process. I was asked to talk about the perspectives of the hiring committee. For us at Wisconsin, we have a hiring committee for every single position. That is not necessarily going to be true everywhere. Some places for sort of entry level positions, whether and I would say the hiring committee concept is probably going to be more prevalent for academic jobs than for jobs in community centers. It really depends. But either way, they should always have a position description. And I encourage you to read it carefully. Now, they're not all written carefully. Some of them are very, formulaic forms, and they're not very helpful to you. But sometimes, like in our institution, we've been very intentional about writing that position description and laying out what we're looking for. And we expect people to read it, and we expect people to respond to it, both in the letter of intent, which we'll talk about next, as well as in the interview process. It demonstrates a level of attention to detail, but it also sets you up for success. This is the beginning of your homework in evaluating the opportunity. So again, sometimes there's more information there than others, but you should always read it carefully. Sometimes there will be a prospectus, meaning there'll be more information behind it, telling you about the institution, the department, what the resources are there. Just again, this is just your homework of gathering all the information that you can. Figure out if there is a search committee or not. If there is a search committee and you can sleuth out who's on it, that is very important homework to do, just like it's very important homework before you go and interview someplace, whether it's a search committee or in person, because in some instances there won't be a committee style interview. But you need to know who you're going to be talking to. When I was interviewing the chair of Wisconsin, getting that list of people who I was meeting with, I researched them all. So I came in with informed questions, but also so I didn't stick my foot in my mouth talking to somebody when there's clearly something that I should know about that individual in advance. Who's the chair of the search committee? And do you understand the process? We have a very, very standard process to mitigate bias in our recruitment processes. So We are happy to share that with the candidates. We do a panel style interview. Everyone is asked the same questions. Those questions are anchored to the competencies, which are reflected in the position description. It's not a secret, but despite sharing that with candidates, it's always amazing to me sometimes how many people don't take that into account and prepare for that. And the committee very much takes that into consideration in terms of who they recommend to advance or not. So try to, ask what's going to be the process. Who will you be meeting with? Will you be meeting one-on-one? Will you be meeting with committee? Will you be meeting with a smaller panel of folks? People will tell you, oh, cover letters don't matter, keep it brief. I will tell you that's blatantly bad advice. The cover letter is your introduction of yourself to this position. That cover letter is going to go with your application or your CV to every person that's going to interview you along the path. And I recently chaired a search committee for another department chair search in our institution, and we actually chose not to invite someone who was very accomplished by their CV based on the tone of their cover letter. So it's really, really important to spend time on this because this is how you are introducing yourself, and it's showing how you've thought about this position and how it's a good fit for you. So it doesn't matter. Yes, spend time on it. Really, your goals for this are not to write, a 10-page War and Peace letter. Nobody wants that, right? But tell the committee who you are. Summarize what your relevant experiences and information have been. It's a little bit like that one-page personal statement that you had to write, right, when you're applying to fellowship and residency. But tailor it to what's relevant for this position. They have your CV, so don't just regurgitate your CV. Nobody wants that either. Like, help me translate your CV. Imagine the search committee is having to review lots of letters and lots of CVs. So again, this is your opportunity to sort of lay out for them what's important in your CV, what's unique about you in terms of what you would bring to this opportunity that somebody else might not. And again, back to that position description, if you're applying for a job and it says that this is a high-pec job on the surgical oncology side, but you want to do HPB, pay attention to that, right? This is a complete mismatch. And I see this all the time because people are just sort of flooding applications out there. Similarly, if it's a transplant HPB job, but the position description says this is a kidney job, then there's an obvious disconnect there. But again, you would be amazed how often this happens when people are just blanket applying for opportunities. So pay attention to the position description, connect with how you're relevant to it in your cover letter, and have someone else read it. You're too close to this. Again, have somebody who's not, you can have somebody like proof it for grammar that's your, partner or someone not in medicine, but I actually mean have somebody else read it that is perhaps a mentor or somebody who is close enough to the field to understand what might be meaningful, but not too close to it to make sure that it doesn't sort of read well and translate what you want to translate. So back to asking about the interview format. Again, this is going to be different with every job, and it's totally legit for you to ask this question. Is it going to be a panel interview or individuals? Totally different interview. If it's going to be a panel interview, I'll talk to you about how to prepare for that. I would say increasingly, panel interviews are going to be the norm because we almost always now do virtual interviews for the first round for a position. This is actually, from a bias mitigation standpoint, really important because we ask all candidates the same questions. So everybody is evaluated through the same lens when we ask everyone the same questions. And it is always super interesting to see how people answer these questions sometimes. For Wisconsin, we ask behavioral-based questions. So those are kind of hard, right? But there is a way to prepare for those. What would you do in this kind of situation, et cetera? So it'll start like easy, like tell us about yourself. Prepare that tell us about yourself response, right? It needs to be very concise. There's an art to doing a virtual interview. There's an art to doing a panel interview. So practice these answers and think about them in advance. Quite honestly, while you won't know what you're going to be asked, you should be able to foreshadow in general, again, based potentially on the position description for our organization, what kind of areas you might be asked in, and you think about those answers in advance. Will it be virtual or in person? If it's virtual, really important to practice that virtual setup. Make sure that you're not going to have any glitches on that day. We're a lot better at this now, but again, Having tech issues is a huge bummer on that day. We usually, when these are scheduled, we have multiple candidates stacked up to interview for efficiency purposes for the committee. I mean, you cannot run over, right? So when you have technical difficulties, it often means your interview is going to get shorter because of that, because there's another candidate to follow you. So really important to know that and to prepare accordingly. And to make sure what's going to be behind you. We've had people show up for virtual interviews from the airport, like sitting in a busy area. I mean, it's just crazy, some of the things that you see. So don't do that. Don't be that person. How long will it be? You need to gauge your answers. If you, sometimes you can ask, if you have there's an admin person leading it, like you can say like, well, how long should my answers be? So that allows you then to prepare again. And usually, we tell the candidates, okay, we have 7 questions for you in the next, 30 minutes or so. So that tells you like my answers need to just be a couple minutes long. And you need to pace yourself, because if you don't leave time for them to ask you those other questions, that just hurts you. And it demonstrates you can't follow instructions or do basic math. Expect it again that the questions are going to flow from the competencies. So we again are very competency driven in our positions. What do we need in this role? That might be what do we need clinically? That might be what do we need academically, because we're an academic organization. That as Dr. Chapman said, these positions rarely are going to be pure HPB, and you have to be willing to share how you're going to have value in all different kinds of ways, and that you're going to be flexible. So we all have parts of our job that aren't our favorite parts of our job, right? And especially when you're first looking at a job, there needs to be increased flexibility, because you need a job at the end of fellowship. But you also, so that gets back to that homework. If you know what they really need and you can say, hey, I'm really passionate about medical student education and I would love to help with that. And I might really have a need in that area. And I can say, great, that's going to serve another need that I have. Or you might say, I really want to do HPB, but I'm also willing to do HIPEC, or I want to do HPB in liver transplant, but I'm also willing to help our organization that's with pancreas transplant. Is the thing that nobody wants to do. So I think, it's understanding what the needs are and being willing to help fill a gap and be flexible. And so think about that. Practice, practice, practice. Again, back to this, having nice, prepared, succinct answers. You can't sit there and kind of ho-hum your way through thinking about the answer to a question. These interviews move fast when you're being interviewed by a committee. And so you have to kind of dive in. So that preparation, that reflection, that thinking about what might I say to this? What might I say to that? You can go online and search behavioral-based interview questions, and you can find hundreds of interview questions. Those are the kinds of things you're going to get asked. So again, these questions should not really globally be a surprise. There'll be some twist on that, but they won't be that different. Answer the question you're asked, not some tangent, and don't talk for too long. And I think we've covered that. And again, ideally have prepared examples or experiences to share when you can. So again, this is making yourself stand out about how you are uniquely positioned to be successful in this position. So just in the last 2 slides, what is a committee looking for? We're looking for somebody who's authentic and has integrity. This is critical, and I think this is critical not just for our organization, that there's demonstrated commitment to values of diversity and inclusivity. We ask a question about this of every single faculty candidate. And again, it is fascinating, the answers that you get. This is something that, again, if you haven't thought about your philosophy and commitment, you need to think about this in advance. Maybe in the Q&A, I can share some examples of terrible answers we've had to this question. And then alignment, again, with what is needed for the role. Articulate your goals, as Dr. Chapman said, and convince me you can achieve them. I am much more excited about hiring somebody who has a plan and knows where they want to go, then even if it's not a perfect fit for us, and somebody who's totally wishy-washy and is sort of just telling me what I want to hear. I'd much rather talk to somebody who's like, here's where I would like to be in 10 years. I know right now that that's not exactly what you need, but this is where I'm headed. And then express your flexibility. But don't be so overly accommodating that I have no idea what you want to do or what you want to be, because that's not very inspiring. And I can't tell if our job is going to actually be able to get you there, or you're going to meet what we need, because it's not authentic. Back to that very first bullet. And then lastly, and most importantly, this should be a fun opportunity for you. You're there to learn as much about us as we are to learn about you. And while we have more leverage in this interaction for sure when you're a fellow, because you need a job, you again should be quizzing us too to see if we're the right culture, the right fit for you, and the right opportunity. And so again, come prepared with questions. There's nothing more uninspiring than somebody who's like, nope, I don't have any questions. They've all been answered. Like that's totally unacceptable every single time. So I don't even care if you ask me the same question you ask somebody else, never give that response. So thanks so much. And I look forward to the discussion.
Thanks very much, Dr. Minter. Our next speaker is Dr. Amar Gupta. He's an HB and transplant surgeon at the Liver and Pancreas Disease Center at Baylor Medical Center in Dallas, Texas. After finishing his general surgery training in New York, he then completed 2 surgical fellowships, one in abdominal transplant surgery at Baylor, and then a second one in HB surgery at the University of Calgary. He has worked at Baylor since 2018, where he specializes in living donor liver transplantation as well as advanced HPV surgery. He is the director of the Abdominal Transplant Surgery Fellowship Program at Baylor. Dr. Amar Gupta.
Thank you very much. I'd really like to thank Dr. Gilbert and Dr. Lee for this invitation. It's very flattering. It's a little confusing. I'm not sure how qualified I am to give this talk, but that may be the Canadian apologist in me. So we're going to talk about the first 5 years. I'm in my 5th year, so I have been through all of these stages. I don't have any disclosures relevant to this, but I do want to let you know this is not a data-driven talk. This is my experience as well as a little bit of pooled experience from some of my peers. And so this hopefully will resonate with a lot of you, but you know, the fact of the matter is there's a lot of paths. There's, you know, no 2 paths are the same. There's a lot of people who will go into fellowship straight into attendinghood in the same institution. There are people who will move to a different institution. And then one of the paths that I took is I did my fellowship in one institution, went away for a little while, and then came back to that same institution. And you're going to be in a different position depending on what your path is. On top of that, obviously, no 2 jobs are the same. You know, the person who's a surgeon scientist at a major academic center is going to have very different needs and wants, as well as career goals from someone who is a clinician working in a community center who is saving lives on a daily basis. And so they're very different. On top of that, the hospital situation you're in, are you private practice? Are you part of a hospital group? How do you get referrals? All of that is very, very different. And to be honest, I believe that this makes a very, very difficult talk. Again, I'm going to go through some of this with my experience, and I hope it relates to a lot of you guys. So very quickly, this is my path and my job. So I did an ASTS fellowship at Baylor University Medical Center in Dallas. I then went up to Calgary and did an HPBA fellowship there. Being a Canadian, I had to get rid of my J1 visa. And so I was very fortunate to be able to spend a year at Toronto General Hospital for a year as a clinical associate. And then I was fortunately recruited back to Baylor, where I am right now. I do liver and kidney transplant as well as hepatopancreatic biliary surgery. I'm primarily clinical. Our hospital is a private practice hospital. And so I am a bottom feeder. I fight for referrals with all of the other surgeons that are in DFW. That being said, I do have a very significant interest in resident and fellow education. So year 1, what do you expect? You've gotten your job, and I remember sitting where you are and I was like, why are you talking to me about what to expect? I need a job. But hopefully that's what Dr. Minter and Dr. Chapman, their talk was for. So you've gotten your job. It's a very, very odd transition. As a fellow, you're operating every single day. That's what you do. You're probably covering 3, 4, sometimes 7 or 8 different surgeons, and you're operating nonstop. And then you come to your regular job, your first job, and you're waiting for the referrals to come in. You're sitting there twiddling your thumbs. Don't be discouraged. This is normal. Use this time very, very wisely, and we'll get into that. It's a little bit unsettling. There's new faces. It's a new environment. And the fact of the matter is you have very, very new responsibilities that are very different. This first year is the base for the rest of your career. So you really, really have to use it wisely. It's probably slow clinically, but this is what's going to make the rest of your career. So I've kind of tried to boil this down into some pearls and pitfalls that at least I experienced. Use your downtime wisely. Again, being private practice, I did a lot of outreach during my first year, visiting referring physicians, understanding what are their needs. You know, the first question isn't, I can do this, I can do that. It's, hey, what do you need? What needs are being unmet for you, and how can I try to help with that? If you're in a research program, if that's something that's very important to you, this is the time to set all the foundation for the research that's happening. Once you're busy operating 3 or 4 days a week, you are not going to be able to do that. So do it now. And then Dr. Chapman touched on this. Look at outside courses. This is a great time if you do want to pursue some more education, something else, to use this time. Everybody is familiar with the 3 A's, and again, this is an order usually of importance. Availability is the most important thing. In your first year, it's very hard to say no. Affability. You can't go and tell your referring physicians how you really feel. You have to be very affable. You have to be the yes person. And then ability is certainly important, but the fact of the matter is, and I'm sure all of you have experienced this with unfortunate surgeons who you think are not as able as they do, it's not as important as the first two when you're setting your first year up. Network. This is unbelievably important. It's great that you guys are all here. This is step one. But it's not only nationally. Network in your hospital. Participate in grand rounds, not necessarily surgical grand rounds. Offer to give the GI fellows talks. Offer to give the internal medicine residents talks. It's very important. Same thing with tumor board. Don't just sit there. Participate. Give your opinion and show the people who are going to be referring med-oncs and your GIs how much you know and how good of a physician you are. Obviously, it's very important to be here, get involved in the meeting, but also in the committees. Start setting up your niche. Both Dr. Minter and Dr. Chapman spoke about how important this is. What are you going to be known for? And you don't have to be known internationally. You don't even have to be known nationally. But when you are 10 years into practice and people mention your name in your hospital, in your community, what do you want them to think about? So start thinking about that now, because what you do over the next several years is going to be important for that. Start identifying mentors and sponsors. They are both very important. They are different. Mentors are very, very good for advice. They are good for promoting the work that you are doing. But sponsors are invested in you. Sponsors are the people that see their success measured by your success. They are the ones that will go out and basically put you on a pedestal and try to get you that job. So identify them. They do not have to be surgeons. They do not have to be HPB surgeons. They can be anybody who is invested in you. I added this one very last, actually this morning, because it's one of those things that you don't really think about, but keep a case log from day one. Number one, you have to have it. When you apply to the American Board of Surgery for your FACS designation, you have to have your first year case log. It's going to be needed for privileging. If you apply for privileges at a different hospital, they're going to ask, well, how many Whipples have you done as a staff? How many hepatectomies have you done? But more importantly, this is how you're going to evaluate yourself. You're going to go back and look at all the cases you've done. I don't only put the case, the indication, talk about the complications that you had. How did you do it? How did you do the PJ? The more information you put prospectively, the more information you're going to have down the road to evaluate yourself. Pace yourself. There's a fine balance between being a yes person and overstretching yourself. Everybody wants to try to do as much as they can, but if you do everything mediocre or even poor, nobody's going to ask you to do anything else. So it's important to say yes, 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 I can do that, but do not overstretch yourself. You have to prioritize what's important now, and more importantly, what's going to be important for you 5 years down the road. This first year, the OR can be very, very treacherous. What I find, I did this. My junior partner does this. Everybody does it. When you're a brand new attending, you will let the residents and fellows do a lot. It's amazing because you are probably the least qualified person to let them do as much as they are doing. But you remember what it was like when you were a fellow and you wanted to do stuff, so you're trying to give that back to them. Resist that urge. It's very, very hard, but resist that urge. Show off your training. All of you, I guarantee, are undervaluing how good of a surgeon you are. Show that off, but with some restraint. Don't overstep your boundaries. And most important, call for help. We tend to be as surgeons, especially as HPB surgeons, we're very proud. We're usually the ones that general surgery or someone else calls in for help. And we see calling for help as a weakness. Do not do that. If you have the privilege and advantage of being in a center where you have senior surgeons, mentors, sponsors, call them. Year two, this is where it gets crazy. Hopefully the groundwork that you laid in your first year pays off and you get very busy, really, really busy. So at this point in time, start lining up, well, what's really important to me and what can I kind of offload elsewhere? This is where you start trying to distill what you want your practice to be like. That being said, don't lose sight of career goals for all of the clinical work. Clinical work is important, operating is important, but if you want to be a researcher, if you want to be an educator, if you want to be in the administrative or business side, this is where you start kind of lining some of that stuff up. At this point, you tend to want to continue the attitude of 24/7 availability and the never say no mentality, but start to look for avenues to offload. You know, if you're in your third year and you just hired a new partner, give that person some referrals. They will appreciate it. They'll love you for it. And it'll give you time to do what's important for you. This is where you really should start to begin to cultivate your career niche. 2 years in is where, you know, I decided that robotic donor hepatectomy is what I wanted to be a part of my practice. And this is where I put 50% of my time into kind of developing that. So this is where really where you kind of make that happen so that, you know, 2 or 3 years down the road, it becomes a reality. Start looking at leadership options. I don't think that anyone would expect you to be a section chief or anything like that 2 to 3 years in, but look at what's available. You know, is there an APD position available? Trainee mentorship? What are the department roles that are available? What are the hospital committees that are available? And definitely in the HPBA, what are the leadership opportunities that are open? This is the time to start really thinking about that. Slow down. The pace that you were going in year one, where you were doing everything, saying yes to everything, is not sustainable. This is where you start pumping the brakes a little bit. This part is extremely important, and it's already been touched on by some of the other speakers. Keep in mind what is important outside of work. Family, traveling, do you want to play bass guitar? Whatever it is, you have to keep in mind that work is not everything, and you will suffer at work if you don't keep that in mind. I firmly believe that this is where burnout can really start if you try to keep that year one pace. The OR is still treacherous. It's always going to be, but it's still there. Don't venture too far outside of your ability. You do want to start pushing your boundaries. But you know, year one is great. You've done a couple of big cases. Don't go and then try to do an in situ perfusion if you've never done one by yourself in year two. Okay. This is where I've seen kind of cowboy-itis rear its head, where it's, you know, I've had some really, really good cases. I've had some great outcomes. And now you're going to kind of go outside of your comfort zone too far and get into trouble. I think that a lot of times, you know, most people would agree it's anesthesia and the scrub nurses that you hear talking about how good of a surgeon so-and-so is. Your 1 year honeymoon period is over. And this is where they're really going to start kind of looking at you and where your reputation is going to be developed. Not a lot of slides for year 4, year 5, because you guys are going to forget everything that I said by the time you get there. But this is really where you distill your practice into what you foresee the next 5 to 10 years being. You can really start cherry picking a little bit. I love it right now. I'll get someone, I'll say, you know what, this is probably better for the junior partner. I'm going to give it to this person, or I'm not available. Quite frankly, I'm too busy. You have to start saying no to things that don't align with your career vision. At this point in time, you firmly establish your niche, start collaborating with people who are doing what you're doing, try to present your work at as many forums as you possibly can. And the most important thing is teach. You don't really know a topic unless you can teach it. And so this is kind of where you've stepped into that role. Don't get complacent. By now, you're probably pretty good at what you do. Start venturing outside of your wheelhouse. This is how you adapt. Don't get left behind. Review and reevaluate. Are you where you wanted to be 5 years ago? If not, if you want to be somewhere else, what can you do to get there? And I find this part really important. I have been accused, especially by my wife, to fall ass backwards into the best mentors. There's no way I would be here without them. Keep that in mind. You did not get to where you are all by yourself, and please give back to trainees, to junior surgeons, to others. So usually I end my talks with a picture of our institution. It's the beautiful overhead view that everyone does. But the more I was giving this, the more I realized how important what's outside of the hospital is. And you know, I really urge you guys not to forget that. So thank you again for this opportunity. I appreciate it.
Our next speaker is Dr. Martin Dibb. He graduated from medical school at the University of Chile, after which he did a 2-year research fellowship in liver regeneration at Harvard. He completed his general surgery residency at Beth Israel Deaconess Medical Center, also at Harvard, and his clinical fellowship in abdominal organ transplant and HPB surgery at University of Toronto. He worked as a transplant surgeon at University of Wisconsin-Madison, and in 2018, he moved back to Chile to develop a live donor liver transplant program in Latin America. He is currently the chief of transplant at Pontificia Universidad Católica de Chile. He is one of the site program directors of the Latin American HPBA Fellowship, the Chile, Brazil, and Mexico. All this makes him uniquely poised to present today perspectives unique to Latin America. Dr. Dibb.
Well, thank you very much for the introduction. Thanks for the invitation to the committee. I'm very honored. So I was asked to give a little bit of the Latin American perspective, not only for future, so Latin American HPV surgeons, but also a little bit of perspective to any HPV surgeon. So my first disclosure is that I owe my career to my mentors, and I think that's one of the points I really wanna talk to you about. And I will give also my perspective with my story and give you a little bit of advice from the things that I've learned. There are multiple ways to get to the same destination, and this presentation is subjective because it includes my story. And the aims of the presentation is to highlight the opportunities and struggle coming from Latin America. But also, I want to show you a little bit of the fellowship that we have created and give you some advice. So this is my story. I came from University of Chile, and I had this huge opportunity as a guy from Chile going to a general surgery residency in Boston, after which I did my fellowship in Toronto, and then I had the opportunity to do my first job at University of Wisconsin. And so this was basically what I'm going to talk to you about, which is this decision of going back home, which was probably one of the hardest decisions I've made in my career. And I think it's illustrative of what you really want to, where you want to go in your path. So the first opportunity came and decision came with this opportunity to go as a med student to Boston, and that was an opportunity that really changed my career. And then looking from a Latin American perspective, looking at these general surgery programs, I was really surprised of how well the training was and how complete the chief residents got their training. And so one of the questions I basically was thinking when I made the decision to go to train in the US was what to prioritize. So there are many things that we want to prioritize when you're training. Some of it is that you want to get the best possible training. You want to also have a little bit of work-life balance. There's some financial aspects that many programs in Latin America, they don't pay you, and so it's difficult to realize which of these items to prioritize. So looking at the path from, this is Chile, but very similar for all Latin American countries, the path of high school, then med school, general surgery, fellowship, and being a staff is quite similar, except when you go to the general surgery programs, many of the Latin American general surgery programs are 3 years. So very different from North American programs, which are 5 years, and they get to a high complexity of cases. And so for Latin Americans, many of them will not go to any fellowship. Some of them will have the opportunity to go to a fellowship in Latin America, which are not necessarily accredited. Many of them, they don't have the volume of cases to be able to get independent. So what many people would want to do is to come to North America for a fellowship and then go back to their countries. Now, that is actually very difficult, and a very low percentage of Latin American surgeons will be able to do that, especially because they don't have more than 3 years of training, or because they basically don't have the contacts. So what many people do is that they do a fellowship over there in Latin America, and then they come and do another fellowship here once they know more people. And that is still very difficult. And but it's what most people that train in the US and go back do. Now, some of them will want to stay as a staff in the US, and I tell you, that's very, very difficult. That's almost impossible. It is possible with an academic appointment, but not having an actual board certification. It's expectations that are over what reality is. So what I did was an unusual path, that I did the long road. So I came from med school and I did my residency here to be able to get board certification, and then I was able to do fellowship and being a staff here. I think all roads lead to Rome, and the real question is, where is your Rome, and where do you want to end up? So I think you need to think very early where you want to go in 5-10 years. And for me, what I chose was to prioritize the objective of training the best I could. For that, it was a long road. I did 2 years of research. I did many steps, including validating my degree with the USMLEs, the ECFMG certificate. There's also some visa issues that you need to really know, because if you get a J1 visa, for example, like Amar was saying, then you need to know that after that you need to get out of the US for 2 years. So if a short advice is try to get an H visa, but it's not very easy either. And then I interviewed, I got very good USMLE scores, but after applying to 30 programs, I only interviewed in 2. And the reason is because they knew me. So I think for foreign people, they need to realize that, good scores is not necessarily sufficient. They need to know you. And I think one of the secrets is to do research and be able for people that are going to interview to know you. I think is very good for foreign people. So anyways, I actually was able to interview in a very competitive program with 1,200 applicants, and they had 100 interviews, only 8 spots. And as a guy from Chile, I was very humbled to be able to get one of those spots. So that changed my career. And I did residency in Boston. I did fellowship in Toronto, and was able to get this job. And 2 years into my first position, I got this call to go back home, because they needed me. So there was a need for developing live donor liver transplant in Chile. There was a very high mortality, and being able to say bye to this dream job at University of Wisconsin wasn't easy. I had an excellent chair of surgery as well, Dr. Minter, and I don't think she forgives me yet. So we developed this live donor liver transplant program, and I want to stop here because I think I want to highlight what is, to me, the key for success. So it's not only a well-trained surgeon, but it's the team that really, acknowledges your training and is able to receive you. So my chairman at the time was Nicolas Jarufe, who's sitting here, and we developed this together. I think one of the key, I always remember our first live donor, he actually asked me, okay, Martin, why don't you show us how they do live donor in Toronto? I mean, that's very different from other surgeons that have gone to other places. And I think it really relates to how you are received. And I think that is key when you're looking for a job. So we developed this program. We have done almost 60 live donors since, and we have been developing even more than my mentors. We have developed laparoscopic live donation, and I think I learned a lot from them. They learned a lot from me, and I think that was good synergy. I also want to highlight something that I learned later. So there is also mentors that not necessarily were in your fellowship, but you start making contacts and become friends with other experts. And David Kwan, who is at Cleveland Clinic, really has been my mentor. He has done kind of telementoring, we say, distant training, and I've been learning a lot from him about laparoscopic living donation. I think once you get a job, you should continue to learn from people, even if they're far away. And so we have been doing an amazing learning curve, and we're proud of it. And the other thing is that in Latin America, mostly, it's not about just putting stitches and being in the OR. You need to get out there. We had to change some laws of live donation, for example, and we have done many things with the Ministry of Health to be able to accomplish this program. So I think, to summarize that, I think it's not only a highly trained seed, I think is the fertile soil, and learning from your environment, learning from the culture where you're gonna go, having a need for you to be there. I think it will maximize the impact that you can make. Having an academic environment is always protective. Having an environment that is more collaborative than competition, I think are those things that you need to kind of smell when you interview. And having this teamwork is key. So one of my mentors in Boston was Mark Callery. And I learned a lot from him. He was the president of the HPVA when they decided to go to America's HPV Association. And one of my passions is to decrease the gap between North America and Latin America. And one of the things is training. So HPV training in Latin America is not as developed, and basically it doesn't have the regulations that we have in North America. I think there are amazing HPV surgeons in Latin America that North America learns from as well. But I think if you look at all the HPV programs, most of them are digestive surgery programs. So they're not fully HPV programs because there's no volume to be able to do that. And so looking at that and looking at the accredited programs at the HPVA, I was part of the educational committee at the HPVA, and looking at all these programs, there's only 2 Canadian programs and the rest are US. So we developed a goal of developing a Latin American program that would be HPVA accredited. And to do that, we needed to increase numbers by combining places. So we met a few years ago. We worked for like 3 years and developed this program where we had 3 sites between Chile, Brazil, and Mexico, and 8 months each. And I think Adnan Al-Saidi and Brendan Visser were absolutely crucial in getting this really done with us. And we also received a donation thanks to Brendan from Stanford, and to be able to have salaries for this fellows that actually didn't need to do my path, which was to go to North America to come back. Why don't we have a program in Latin America that people will benefit from? They will learn to do Whipples, they will learn to do liver transplants, and then go back to their countries and have a high impact. So that's our fellowship, and we're very happy with it. These are the three initial fellows that started last year, two Gabrielas and Jose. So we're very proud of it. The outcomes have been amazing. They have learned a lot in the OR, but also to live in 3 different countries also brings a lot of life experience. And so I think that has been very, very successful. Patients have benefited from it, and I'm sure they will when they go back to their home countries. And then we have benefit from it. We have collaborated as the 3 groups with Wellington, Paulo in Sao Paulo, with Carlos Chan, Ismael Dominguez, and the entire staff. I think it has been helpful for us as well. If we look at the numbers of the first 8 months of the fellowship, mostly they have met the requirements of the 2 years, which is actually quite amazing. And so we're also we have a minimal invasive simulation lab that has been developed over the past several years with Julian Varas in Católica, and we're planning to do this distant learning using artificial intelligence. So then he has a program where we can do simulation from distance, and it's actually quite successful. And they're doing projects even in Africa from North America or Latin America. So I think that will help our fellowship as well, which is 3 sites. So in terms of lessons learned and take home message, you need to get good mentors. I think ask for advice is very important, and keep in touch with them along your career. You need to learn and ask yourself, where is Rome? Where do you want to be in 5, 10 years? You need to get a first job and prioritize your partners and your team. I think that's crucial. And I think get the place where you will make the highest impact that will make you happy and your family happy. Work on developing a strong system. It's not just the OR, it's the nurses, it's the ICU, it's the other specialties. It's also, you know, even the politicians, the authorities, you need to educate them as well. Don't make changes for the first 6 months. That's an advice a mentor gave me. People hate changes, and once you get there and they get their trust, your trust, they trust you, and then you make all the changes you want. But we want to make changes the first 6 months. That's a mistake. And do a family first approach. That's incredibly crucial. I agree with Omar. This is my family, and I think it's very difficult to do. It's a decision you need to make every day. So thanks to my mentors, thanks to my team, and thanks to everyone.
I think unfortunately we're a little bit out of time for a Q&A perspective, and I do think there is a session that follows here. So we'll probably have to hold questions, but I will say that I think all of our panelists would be happy to, if you come up to them and ask them personal questions about their particular topics today, as well as their travels through their careers. So I want to send again, thank you to everyone for attending, as well as everyone on the panel today. Thank you all very much.